All right. Good morning and good afternoon to all our colleagues around the world. Welcome to today's webinar. To those from not from Malaysia, the music that you heard just now is from the Dayak tribe from Sarawak. I'm Dr. Satya Subramaniam. I'm the Honorary Secretary for the Academy of Occupational and Environmental Medicine Malaysia. Thank you for joining today's webinar, which is the 11th in the series of complimentary webinars organized by AOEMM in conjunction with the 24th Asian Congress on Occupational Health 2026. So this Congress is held every 3 years, and AOEMM is proud to be the host this time, and we welcome all OH practitioners in the region and around the world to participate. So this year we'll be having the conference from 5th to 8th August 2026 in Kuching, Sarawak, Malaysia. So thank you for your time in attending today's webinar. Just before we introduce the speaker, just want to go over some house rules. So please keep your microphone muted at all times. And we welcome all of you to share your questions using the chat box. And when you're doing so, please include your name and where you're from. Please stay professional and respectful at all times, and please do not share any confidential information or information relating to personal and sensitive information. We will be recording this session for later sharing in our website. Next slide, please. Okay, today our speaker is Dr. Ely Zarina, binti Samsudin. We are honored to have her today. She's a public health medicine specialist and senior lecturer at Universiti Teknologi Malaysia. And she's here with us to speak on the topic of beyond tangible hazards, addressing psychosocial risks in the workplace. So Dr. Ely specializes in workplace mental health and management of psychosocial hazards. She has over 25 publications and is also a contributor to National Occupational Health Guidelines in Malaysia. So without further ado, let's hand this over to Dr. Ely. Over to you.
Okay, thank you very much, Dr. Satya. I will share my slides now.
All right.
Can everyone see my slides clearly?
Yes.
Yes, and my voice is okay?
Yes.
All right, thank you very much. So, Assalamualaikum and a very good afternoon to everyone. First of all, I would like to thank the Academy for inviting me to give this talk today. And also to Dr. Satya for the fine introduction earlier. My name is Dr. Ely, and I'm happy to share some insights on psychosocial risk in the workplace, which has been my primary research interest for the past decade. So this is the outline of the presentation today. First, we will begin by understanding psychosocial risk, followed by some exploration of findings from peer-reviewed publications on psychosocial risk, its determinants and outcomes, and then we'll go over some best practices in psychosocial risk management, and finally conclude with some take-home messages and call to action. So in today's world, this is an important topic because many of the work-related problems that we have today are driven by hazards that we cannot see. And to begin our understanding of this non-tangible hazard, we have to know what it means. So psychosocial hazards, to put it simply, are aspects of the work environment, job content, and organizational conditions that can impact how workers experience their work and therefore affect their health and work outcomes. Whereas psychosocial risk is the likelihood of harm when a worker is exposed to these type of hazards. So today, psychosocial risk is acknowledged as a global OSH issue, affecting all countries and all professions due to its multi-level impact. On individuals, psychosocial risk can result in stress, burnout, psychological disorders, physical ill health, and unhealthy lifestyles. On organizations, exposure to psychosocial risks can result in poor performance, increased error and accidents, reduced motivation and job satisfaction, higher absenteeism and presenteeism, as well as an increased staff turnover. On economies, the impact of psychosocial risk is lost productivity, largely stemming from a higher absenteeism and presenteeism, and burden on healthcare, as well as high economic burden. And in fact, the WHO and ILO has estimated that 12 billion working days are lost to depression and anxiety, which are conditions closely associated with exposure to psychosocial risk, and that this has led to 1 trillion USD lost cost to the global economy. Moreover, this issue is increasing in its significance due to its increasing trend. So, data from the Global Workplace 2021 report, which is based on a global poll conducted by Gallup, shows that the prevalence of job stress has been increasing and has reached a records high in 2020, primarily driven by the COVID-19 pandemic and changes revolving around work demand and work organization. And in fact, psychosocial hazards has been suggested to be on the verge of surpassing many other occupational hazards in their contribution to ill health, injury, and disability, direct and indirect costs, as well as impact on businesses and national productivity. So there are significant occupational health problems because they are hazards with very real consequences. So let us explore the 10 types of psychosocial hazards outlined by the ILO. So they can be divided into psychosocial hazards that revolve around the job content as well as the job context. So in terms of job content, some psychosocial hazards that can be present in the workplace include things like work overload or underload, high levels of time pressure, task design with a lack of variety or perceived to be meaningless by the workers or underutilizing skills, shift work, inflexible and unpredictable work schedules, having to work with faulty equipment and being exposed to things like noise and odor in the working environment. Whereas in the context of work, some psychosocial hazards that workers may be exposed to include things like negative organizational culture with poor communication and low levels of support for problem solving and personal development, role ambiguity, which is unclear information about one's job expectations, or role conflict, which is conflicting demands from different sources, career stagnation and uncertainty, under promotion as well as over promotion, and job insecurity. Lack of control over work, social isolation, poor relationships with superiors, and interpersonal conflicts. And finally, conflicting demands of work and home. So, how does job stress or job strain result from exposure to those 10 types of psychosocial hazards outlined earlier? So, to explain this, I've chosen to use the Extended Job Demands Resources Model, JDR model. There are many work stress models available today, but the one I've chosen today is widely established and known. So, basically, according to this JDR model, every job has its own job demands and job resources. So, job demands are aspects of work that require sustained physical and psychological effort on the part of the worker and are thus associated with physiological and psychological costs. For example, high work demand. Whereas job resources are aspects of the work that help the worker achieve organizational goals, reduce or mitigate the impact of job demands, and fosters personal growth. For example, having good supervisor support. Okay, and there's also personal resources, and personal resources are the worker's positive belief about him or herself and the world, and are traits generally linked to resilience. For example, self-efficacy. So according to this JDR model, there's two core processes that happen and operate simultaneously depending on the balance between job demands and job resources. So the health impairment process arises when there is excessive job demands and a lack of job resources, which will then translate into exhaustion and poor psychological health among the workers. Whereas the motivational process is triggered by abundant job resources and personal resources, which will then lead to continued work engagement and positive organizational outcomes. So now that we have some understanding of psychosocial risk, let us see how it can arise from work and translate into measurable harm using evidence from practice. So the first case study is related to workplace bullying in healthcare. And workplace bullying is a type of psychosocial hazard under the category of interpersonal relationships that was outlined earlier. And it is defined as a situation where an employee is exposed to frequent harassing behaviors from superiors or co-workers over a prolonged period of time, and in which they find it difficult to defend themselves against these actions. So there are four papers related to this case study, and the first one is a systematic review to examine the prevalence, risk factors, and outcomes of workplace bullying among junior doctors. So in this systematic review, based on 18 articles reporting on a total of 9,597 junior doctors, it was found that the prevalence of workplace bullying was varied, but was significant. So 30 to 95% of junior doctors report being bullied at work. And this has led to not only individual outcomes, such as mental strain and burnout, but it has also led to organizational outcomes, including job dissatisfaction and increase in the frequency of accidents. So this study highlights that workplace bullying negatively impacts not only workers, but also organizations. The next three papers are based on the findings of a multi-center cross-sectional study and multi-level analysis of a universal sample of junior doctors working in central Malaysia. So in this study, the operational definition of workplace bullying use was rather conservative to reflect persistent exposure to negative actions as well as the subjective and interpretation of being victimized. So the workplace bullying found in this study was 13%, which means that at least 1 in 10 junior doctors report workplace bullying in Malaysia, and this is quite significant. In terms of individual factors, junior doctors with a higher negative effect, which is a predisposition to experience negative emotional states, and junior doctors with higher neuroticism, which is a type of personality trait, had higher odds of workplace bullying compared to their peers. And in terms of organizational factors, those working in departments with positive organizational climate, high degree of procedural, interactional, and distributive justice, as well as organizational support, and certain types of culture and leadership styles were associated with reduced odds of workplace bullying among junior doctors. So this study highlights that a significant proportion of junior doctors in Malaysia experience workplace bullying, and that this is associated significantly not only with individual factors, but also with organizational characteristics. So for the second case study, we will look at burnout among public health workforce during the COVID-19 pandemic. So burnout is not a psychosocial hazard, but rather an outcome to exposure to psychosocial hazard. And it has been included in the International Classification of Disease 11th version, ICD-11. as an occupational phenomenon, and it is defined by WHO as syndrome resulting from chronic workplace stress that has not been successfully managed and characterized by three dimensions. So the first one, feelings of energy depletion or exhaustion. Secondly, feelings of negativism or cynicism about one's job. And thirdly, reduced professional efficacy. So the findings were based on a multi-center cross-sectional study and using stratified random sampling of public health providers in 10 district health offices in Johor and multiple logistic regression analysis. So in this study, the prevalence of burnout was found to be 45%. And 94% of the public health providers were disengaged and 46% of them were exhausted. In terms of individual factors, those with younger age had higher odds of burnout compared to their peers. And in terms of work-related factors, so things like being involved in the COVID-19 management for more than 6 months, high levels of emotional demand, low levels of role clarity, medium levels of job satisfaction, and low levels of organizational justice was associated with a higher odds of burnout. So this study highlights two things. So first, a significant proportion of the public health providers experienced burnout during the COVID-19 pandemic, and that individual characteristics, job content, and organizational characteristics influence this. So we move on to the third case study, and this case study is about psychosocial safety climate, PSC, and workplace violence. So workplace violence is another type of psychosocial hazards under the same category, interpersonal relationships, and has been defined by the WHO and ILO as incidents where staff are abused, threatened, or assaulted in circumstances related to their work and involving an explicit or implicit challenge to their health, safety, and well-being. Whereas PSC is a facet-specific dimension of organizational climate and is defined as the shared perception within an organization about its commitment to supporting workers' mental health and creating a psychologically safe work environment. So in PSC, there are four basic dimensions. So first, management priority. So the management prioritizes workers' psychological well-being in situations where organizational productivity and workers' psychological well-being have conflicting demands. Okay, and then secondly, management commitment and support. So the management commits strong emphasis on safeguarding the workers' psychological well-being by resolving issues assertively and effectively. Third is organizational communication. So there is an effective and efficient communication between the organization and the workers with respect to psychological well-being and safety. And finally, organizational participation or involvement, where organizational participation is encouraged, where every member of the organization either takes part in or contributes towards the protection of psychological health in the organization. So this was a narrative literature review based on a synthesis of the previous literature. So in this study, emerging evidence found that PSD had not only a direct impact on workplace violence, but also an indirect impact on workplace violence by encouraging adaptive coping. So this diagram, this figure actually shows the hypothesized direct influence of PSC on workplace violence. And it's based on the JDR model as well as the PSC theory. So in high PSC organizations, management will demonstrate their priority and commitment and would implement some measures towards workplace violence prevention, such as zero tolerance for workplace violence policy, psychosocial risk assessment, and investigation and management of workplace violence incidents. And this will then translate to reduced job demands due to a lower emotional demand because of lower incidences of workplace violence incidents, which will then prevent exhaustion and improve the psychological health in the workforce. Okay, at the same time, they will also demonstrate organizational communication and participation by implementing supportive practices that center around this. So they may implement things like workplace violence reporting procedures, training on techniques on how to recognize and report workplace violence, as well as debriefing for healthcare workers who've experienced workplace violence. And this will then lead to an increased job resources and increased access to organizational resources for workers who experience workplace violence. So this will then lead to continued engagement and positive work outcomes. And to support this hypothesis, there are presently studies conducted in Taiwan among Taiwanese hospital nurses that showed that high PSC was linked to lower prevalence of workplace violence. And the authors attributed this to having better policies and practices, as well as the healthcare workers being more willing to communicate their concerns. So this study shows that PSC may be a viable approach to mitigating workplace violence and can enhance workers' psychological safety and health. So now that we have given all this evidence, what can OSH do? How should OSH respond? Okay, so to answer this, we need to look back at how OSH management has evolved over the years, from reacting to visible accidents and injuries to now recognizing that work itself can be a source of risk. So, health today is not solely defined by the absence of injury, but WHO has redefined health to encompass physical, mental, and social well being. And the systems and the frameworks that we have today reflect this shift, which where they include psychosocial hazards as part of a systems-based approach. So for an effective risk, psychosocial risk management, there should be three main components. So first, a legal mandate. Secondly, systematic risk assessment. And thirdly, evidence-based risk management. Okay, so at the international level, there are some conventions related to psychosocial risk. So the ILO Convention on Occupational Safety and Health, the ILO Promotional Framework for Occupational Safety and Health Convention, as well as the ILO Violence and Harassment Convention. So these are legally binding when a country ratifies it. But even in contexts where it is not ratified, they still provide internationally accepted benchmarks that organizations can voluntarily align with. Okay, and they provide for the implementation of national OSH policy, preventive culture, employers' responsibility, worker protection, as well as continuous improvements for addressing psychosocial risk in the work environment. At the national level, governments can develop and enforce OSH acts, regulations, policies, and guidance to control psychosocial hazards at work. And as OSH practitioners, we can collectively engage with stakeholders and advocate for these types of acts, regulation, policies, and guidance. At the organizational level, we can take a proactive and risk-based approach and implement some policies, risk assessment, risk control, risk communication, and continuous improvement to prevent and mitigate a psychosocial risk present in the workplace. And how we can do this is by embedding psychosocial hazards in our existing OSH management systems. So next, for risk assessment. So for risk assessment of psychosocial risk, there is three components. So firstly, a validated psychosocial questionnaire. So the one that I've chosen to share today is the Copenhagen Psychosocial Questionnaire because it is widely known and established and available in many languages. But there are some other psychosocial questionnaire as well. For example, the Job Content Questionnaire. So as long as it's validated, so this questionnaire will be used to assess the presence, the frequency, the duration, and the intensity of psychosocial hazards present in the workplace, as well as the workers' well-being. So that's the first mode of assessment. At the same time, we should also review organizational indicators from the company records because reviewing this data will suggest to us whether there is a significant problem or not. So we should look at absenteeism, presenteeism, occupational accidents, incidence reports, compensation claims, as well as turnover rates. And then at the same time, we should also include a more qualitative component of assessment because the previous two were more quantitative in nature. So we should also consult the workers. So conduct worker consultations, get the input from supervisor and workers, health and safety committees, as well as focus groups wherever possible. So with combining the findings from all three, we should combine them and triangulate the data, which will then be used to guide risk evaluation, where we can categorize the psychosocial risk as low, moderate, or high risk, and that will then guide risk management. So, for risk management, okay, so there are three global risk management frameworks that are available today, and they are all evidence-based because they were developed based on a synthesis of previous literature, best practices, and data. And the first one is the WHO Healthy Workplace Model. And this framework outlines how to implement a healthy workplace program. And in its reference document, it highlights how to mobilize, assemble, assess, prioritize, plan, do, evaluate, and improve aspects of the work and environment to improve psychosocial risk in the workplace. And then we also have the NIOSH Total Worker Health framework, which is a framework that combines occupational and safety and health protection with workers' health promotion. So this framework has in its reference documents policies, programs, and practices that addresses the physical and psychosocial work environment in its reference documents via its Total Worker Health Toolkit. And then finally, we have the ISO 45003 standard. And this framework provides for the guidance for psychosocial risk assessment and management as part of the occupational safety and health management system. And in its reference documents outlines things like policy, planning, support, operation, performance evaluation, and improvement. So, as with other types of hazards, we can apply hierarchy of control for psychosocial hazards as well. And this hierarchy of control has been adapted to reflect the NIOSH Total Worker Health as well as psychosocial hazards. So, based on this hierarchy of control, where possible, we should eliminate negative working conditions. And then we should try to substitute safer and healthier work processes and practices. We can redesign the work environment so that the psychosocial risk are mitigated or prevented. We can introduce some administrative controls, for example, training. And finally, we can encourage personal change by encouraging safe work practices. So these are some specific organizational level interventions that we can take, and they all center around the 10 types of psychosocial hazards outlined by the ILO that we've explored earlier. So some Practicable workplace actions that we can take include things like ensuring adequate staffing level, assigning reasonable deadlines, assigning tasks according to experience and competence, ensuring working hours are reasonable and introducing planned breaks, preventing exposure to hazardous agents in the working environment, as well as providing appropriate lighting, equipment, air quality, and noise levels. Implementing a sort of open communication channel with support for problem solving and personal development. And also some further actions that we can take include things like assigning clear work roles, reporting structures and performance requirements, introducing some career training prospects, incorporating workers' feedback in job design and work organization for a more participatory approach. Having a supervisor training to ensure supportive supervisor-worker relationship. And finally, we can try to introduce flexible working arrangements where possible. So what is the evidence for these organizational level interventions? So according to this umbrella review, which is a systematic review of systematic reviews, and it includes 52 systematic reviews and 957 intervention studies. So they concluded that organizational level interventions as focusing on changes in working time arrangements had strong evidence for improving the psychosocial work environment, health, and retention of workers. So these are things like having flexible working arrangements and interventions focusing on work tasks or work organization. For example, increasing worker participation in decision about tasks to increase their autonomy, and interventions focusing on improvements of the psychosocial work environment, such as enhancing social support and communication, as well as implementing some sort of feedback systems. So these had moderate evidence for improving the psychosocial work environment, health, and retention of workers. So all these interventions have been shown to be effective by this umbrella review. And the next paper is a paper that was published based on a longitudinal study that a longitudinal studies that examines PSC as an upstream organizational resource among Australian school education workers in 18 schools. So they found that PSC was able to moderate the effect of emotional demand on emotional exhaustion, which then reduces job demands, as well as other findings. So PSC again has been shown also to be possibly effective as well. Next, we have individual level interventions as well. So these are interventions focusing on equipping the workers with skills and capabilities to manage any workplace stress. So these include things like skill-based approach, for example, stress management training, coping skills training, and time management skills training, as well as a cognitive or behavioral approach, for example, counseling or cognitive behavioral theory approach, or problem-solving skills and training. And according to the systematic review, so interventions with a CBT approach were effective at reducing stress, anxiety, and burnout, and interventions using relaxation techniques, which is the mainstay for many of the stress management training modules, had a positive effect on anxiety, stress, and burnout. So this brings me to my last two slides. Okay, so first, there are three messages I would like for you to take home from this presentation. So first, psychosocial hazards are real occupational hazards. Okay, and there's robust data linking psychosocial risks to ill health, work errors, reduced productivity, high turnover, and other adverse organizational outcomes, which is why we must act. And thirdly, a multifaceted combined approach, combining both individual level and organizational level approach to risk control of psychosocial risk may be more impactful and sustainable in the long term, because individual level organizational level interventions actually addresses the root cause of the problem, and combined with individual approaches to support worker, it may lead to more sustainable impact on the organizations. And finally, what can we as OSH practitioners do? Okay, so firstly, we can begin by treating psychosocial hazards just like any other hazards. So we can integrate them into our risk assessment, for example, HIRAC, OSH audits, and routine surveillance. We should also aim to assess psychosocial risk systematically and periodically, not just in response to crises or incidents. We should, where possible, try to shift our intervention upstream. So from individual level to organizational level, or the best case scenario is using a combined approach with both, because it has been shown to be lead to more sustainable outcomes. And finally, we should normalize psychosocial risk conversations by increasing awareness and removing stigma as a barrier to action. So my final message is this: psychosocial hazards may be invisible, but they are measurable, they are preventable and manageable. And it is central to the future of occupational safety and health practice that we address this issue. So, with that, I thank you for your kind attention. I will now pass back the floor to the moderator. Thank you very much.
Great. Thank you very much, Dr. Ely, for that really wonderful and interesting presentation. Particularly what stood out for me was I really liked how you differentiated the interventions between organizational and individual. I totally agree with you. It allows for a more holistic approach to managing psychosocial safety at the workplace. Thank you.
Thank you.
Okay, so let's move to Q&A. We've got a few questions. So let's go with the first one. So Dr. Shakir from Malaysia is asking, he said, you're mentioning regarding best practice of using COP SOQ for risk assessment, and how would it be different compared with the latest DOSH Malaysia guidelines on PRISMA that uses LEO 26 and EPC 23?
Okay, thank you. So thank you for the question. Yes, actually, DOSH recently came out with the guideline on psychosocial risk assessment and management for the workplace. But the COPSOC is the one that I put in my slides, because it is widely used across countries globally, and it is available in many languages. I think it was originated in Denmark, so it's in Danish, as well as, but it's available in like German, French, Spanish, English, Persian, and all that. So, and it has like 44, the short version has 44 items. So it's pretty much feasible lah to conduct psychosocial risk assessment using that. As for the PRISMA guideline, that one is a different kind of tool. It's mainly based on JCQ. And the job content, I believe the job content JCQ methodology. So it's a bit different. Like there are various tools that users is based on different work stress models, but ultimately, as long as it's validated and you're comfortable to use it, I think it will be fine to use either or.
Thanks, Dr. Ali. Next question from Muhammad Idris Salim from Malaysia as well. So his question is, would the tools shared be able to differentiate occupational and non-occupational psychosocial factors?
Okay, so thank you for the question. So COPSOC, for example, the COPSOC questionnaire that I've used, that I've recommended, it has several aspects that it just Okay, so it assesses several things. So mainly assesses the psychosocial hazards, the 10 types of psychosocial hazards that I've outlined earlier. So demands at work, work organization, job content, interpersonal relationships and leadership, as well as individual factors and health. So as with so because in that questionnaire, it also assesses well-being and individual factors. So any sort individual contributors of this will be reflected in the questionnaire. So I believe that it is able to differentiate, and when we assess psychosocial risk, we should understand that in today's world, the prevalence of mental health issues at work is actually increasing, and exposure to psychosocial risk can either contribute to new sort of mental health conditions among workers or intensify the workers' existing conditions. So we can take that into mind and use that tool, and be mindful that yes, of course, the workers bring in their own individual factors to the workplace and their own pre-existing conditions. But with that tool, it can also show you the work contributors, the psychosocial hazards that are present in the workplace that can intensify um, poor mental health. So we can act on it that way.
Okay, thanks, Dr. Ely. Next question from Nuri Purwito from Indonesia. How can we implement psychosocial risk management in the SME sectors, considering many difficulties on organizational and other resources compared with formal sectors?
Okay, so small, thank you for the question.
Yeah.
So small SMEs, yeah?
Yes, small,
Okay.
medium industry, yeah.
Okay. So um, be, interventions addressing psychosocial risk, it doesn't have to be expensive in order for it to work. So if you have resource constraints, firstly, I think you can start off by normalizing the conversation and improving communication surrounding psychosocial risk in the workplace. And then you can do your risk assessment. And there are some low cost but high impact organizational intervention that you can do. For example, you can improve role clarity. You can improve supervisor supervision. You can improve communication. Communication itself is easy to implement, but it's, when the workers feel that they can communicate and have their voices heard, that's already like a positive impact on their motivation and job satisfaction. So not necessarily interventions shown just now in the slide, all the different organizational level intervention, they're not all costly. Some of them can be implemented quite reasonably easily and will yield to improvement in the psychosocial work environment. And the key here is not for you to solve everything immediately. Continuous improvement is key. Okay, so you start off somewhere. We all have to start off somewhere, and we try to introduce all these interventions, and then we repeat our risk assessment to see if there's any impact on the exposure to these type of hazards, and whether there's any improvements in the organizational indicators that are present in our company records.
Thanks, Dr. Lee. Next question is from Rusna from Malaysia. Hi, Doctor. Can you give some tips to SMEs on how to start ID hazard and assess in their hierarchy?
Sorry, ID hazard?
I'm not sure what is ID hazard here. Rusna, maybe if you could elaborate a bit more on your question. So while we're waiting, let's move to the next question from Muhammad Idris again. So the question is, any study conducted in oil and gas, especially in offshore works?
Any studies on what, sorry?
Oil and gas sector.
Related to psychosocial risk?
Yeah, I think so.
Okay.
Yeah.
From my experience, a lot of the studies on psychosocial risk has been conducted in industries, like for example, healthcare industries. There's a lot of papers and literature surrounding that. There are some papers that are a bit more isolated and includes some from other industries as well. As for all sector industry, I believe there must be some, but in any case, the oil sector industry is quite unique in sense that it's a high demand kind of industry. But with regards to psychosocial risk, even if the findings are not there yet, you can still apply the same principle actually, and basically not try to we're not trying to reduce we are not trying to eliminate demand at all, like completely. Because there's actually a thing called eustress, which is a positive stress, and it is when workers perform optimally, as opposed to distress, which is where workers experience harm. So the oil and gas sector can implement those kind of measures, and basically try to create a work environment where there is not excessive work demand, and coupled with adequate job resources to support the workers in achieving organizational goals.
Thanks, Dr. Ely. Okay, so back to Rusna. So the question in more detail is, can you give some tips to small and medium industries on how to do hazard identification for their hierarchs? Hazard identification, risk assessment, and risk control.
Okay, so this is on hazard identification, right? HI?
Yes,
Okay.
that's right.
So basically what you need to do, well, in Malaysia we have the hierarch. So the hierarch, there's a guideline on it, and it's very structured and systematic. So for hazard identification, what you need to do is, first, of course, you need to go to that workplace, introduce yourself, and then get the work process flow, and consult with both the workers and management. And at each sort of unit or station, you can try to see what types of hazards are present. So there are many types of hazards. There's safety hazards, there's health hazards, which is comprised of chemical, biological, ergonomic, psychosocial, and other types of hazards. So in terms of psychosocial hazards, it's mainly you can't see it, right? Because it's intangible, but you can, through your worker consultation, get feedbacks from the workers when they tell you about it. So that is how I would suggest for you to approach it, because other types of hazards are quite visible, are more visible than psychosocial hazards. So psychosocial hazards, it requires for you to adopt a more the method that I've outlined earlier. So the validated questionnaire, the worker consultation, as well as the looking at the organizational data. And when you do hierarch, you would review all the organizational records and things like that anyway. So it's just a matter of consulting with the worker and asking them about it specifically.
Thanks, Dr. Lee. If I can comment a bit more on that. So I suppose identifying hazards when it comes to psychosocial risks, the conversations with the management is very key, especially at the beginning, right? Just because you're actually going to be going into a lot of organizational factors. So getting the management on board at the start is critical. Right?
Okay, I think to answer that, to add on to
Yeah.
that, I think the biggest because psychosocial hazards are intangible, some managers, not all, may not realize the importance of it. And how do you get their buy-in? So I would suggest three things. So first, you need to frame psychosocial risk as a business risk. So you can look at the organizational impact, for example, absenteeism, presenteeism, turnover, worker retention, productivity, all these things that are very aligned with what the organization wants to avoid, right? So that is how you would do it first, framing it as a business risk. Then you can try to use data that they trust. So company records. There's hard data there, right? You can just show them, look at this trend is increasing and all that. We have a serious problem in this unit or this department, for example, we have to do something about it. So use that data. And thirdly, try to frame management and leadership as a part of the solution and not the problem. Okay, so that's very important as well, because I think nobody wants to feel attacked, right? And it is our collective responsibility to try to improve our psychosocial risk environment anyway. So we try to get their buy-in by framing them as part of the solution. They're not the problem. We are trying to fix this together, and use the data that is available to you.
Thanks, Dr. Lee. So next question is from Dr. Abu Hassan, AOEMM President. So Dr. Abu's comment is, fatigue is one of the key issues that lead to errors and the consequences. It's relatively better handled by the industry at large, for example, oil and gas sector, but it remains a major issue for healthcare workers almost universally. So what can we do differently to address this issue?
Okay. So fatigue, as I believe from its definition, is temporary tiredness that improves with rest. But a more serious implication of this is burnout, because burnout is a condition that basically stems from chronic workplace stress exposure that is poorly managed, and it doesn't really improve with normal rest. So both are very important to manage, because fatigue and burnout can result in catastrophic accidents. And as we've seen, from the previous incidents that happened not only in Malaysia but globally as well. So sorry, can you repeat what Dr. Hassan said? He wanted to know
Okay.
specifically.
Yeah, so what can we do differently for healthcare workers?
Okay, so for healthcare workers, I believe that they've been trying to address this for a while. When I was a house officer, half of my attachment was not shift-based. So we were working, I think, 48 hours on call. But then halfway through my rotation, they included the shift system. So I think this has been one of the measures that they would want to improve lah, in terms of fatigue and, commuting injuries, commuting accidents and things like that. But shift work is one of them. And then fatigue, I think would be best by, I mean, it's a very it's a very heavy topic, because there's a lot of problems in the health workforce because of insufficient number of staffs. Okay, when there's insufficient number of staff, of course, the workload gets higher, right? Because there's not enough people to rotate and things like that. So I think it comes down to I think at a national level, they need to decide this, and couple it with political will to actually move this problem and prevent it. I mean, that's all I can say about that lah. All right.
Thanks. Okay, we still have some more questions. We'll do our best to answer them before the time. Next question is from Dian from Indonesia. What would be the measure of success on the implementation of psychosocial risk management, short to long term?
Okay. So thank you for the question. So some impact from your psychosocial risk management can be seen quite shortly. For example, things like engagement, increased reporting, that can be seen, I think, quite fast. But other changes, for example, health outcomes, they may take a little bit more time, and other things like culture. So culture, organizational culture is like a shift in paradigm, right? And that will require um, longer period of time as compared to, for example, engagement. So, but you will see, as long as you see some improvements, and that's fine, because you're going somewhere at least.
Thank you. Next question is from Dr. Dilshad from Turkey. So there is a reversible reaction between psychosocial risk and occupational accidents. What is your opinion about this issue?
A reversible
Reaction
relationship between a reversible reaction
between
between
psychosocial risk and occupational accidents. So I think it's just about the link of psychosocial risks and accidents at the workplace.
Okay, all right. Okay, so I think thank you for the question. I believe the question is asking me to clarify the relationship between psychosocial risk and workplace accidents, correct?
Yep.
Okay. Okay. So basically psychosocial risk can result in poor organizational performance, right? And also increase in accidents as well as errors. So medical errors or any errors in the workplace. And um, the the mechanism to explain this would be that when workers are exposed to psychosocial risk, they get stressed. And when they are stressed, their attention span, their their decision-making process, and sometimes even when they're fatigued, because there's a fatigue element in that aspect as well. So that can be the consequence of this prolonged and chronic job stress. Okay, that will then translate into things like errors and in accidents. So that's how I would probably explain it, the mechanism of action linking psychosocial risk to accidents and increased errors.
Okay, thank you very much, Dr. Ely. So in the interest of time, I think we need to close the webinar for today. So I encourage those others who still have questions, you can still reach out to Dr. Zarina through your email address. We'll drop in your email address in the chat shortly. So in closing, I'd just like to once again highlight, first of all, let's all give Dr. Ely a round of applause. Thank her for a great webinar today. Thank you. In closing, I just want to remind everyone about our exciting conference happening later in August this year, the 24th Asian Congress on Occupational Health 2026. So look forward to seeing all of you in Kuching in August. Next slide, please. So registration is now open, and you can also submit your abstracts as well. And so let's hope to receive as many as possible and see you all there. Next slide, please. And what's coming next? We have the next webinar in this series of complimentary webinars. And the next one is on the 12th of February, between 2 to 3 p.m. Malaysian time, by Prof. Dr. Retneswari Masilamani from Universiti Tunku Abdul Rahman, Malaysia. She'll be speaking on the topic of workplace wellness, finding the right balance between sitting and standing. So look out for the invite on that. Next slide, please. Yes, thank you very much. And once again, we provided the QR code. You can come and look at our event website and also register interest so that you can also be updated, kept in the loop and updated on future webinars. Thanks, everyone. Have a nice day.
Okay, thank you, everyone.
Take care. Thanks, Dr. Ely.
Thank you.